Hello and welcome to today's webinar. We respectfully acknowledge that the land on which the speakers live, work, and play is Treaty 6 territory in Western Canada, the traditional meeting ground and home for many First Nations, including the Cree, Saulteaux, Niitsitapi, Blackfoot, and Nakota Sioux, and Métis people. We acknowledge their diverse histories and cultures, and we pay respect to all Indigenous, which is the First Nation, Inuit, and Métis people from coast to coast to coast, for their past and ongoing contributions to society. We strive for respectful partnerships with Indigenous people as we search for collective healing and true reconciliation. My name is Dr. Kevin Skoblenick, and I'm excited to be your moderator for today's webinar. I'm a graduate from the FR Emergency Medicine program at the University of Alberta, and I currently work as an emergency physician at the Royal Alexandra Hospital in Edmonton, Alberta. I also have an appointment with the University of Alberta as a research scientist in the Department of Emergency Medicine. My research focus is actually on the neurophysiology of addiction and behavioral emergencies, and I'm looking for potential treatments for novel interventions in the emergency department. My disclosures are as follows. I actually don't have any true disclosures. I have a financial relationship with the Department of Emergency Medicine, as I have a stipend from them, which is in the College of Health Sciences at the University of Alberta. Our webinar topic was independently conceived by the Scientific Planning Committee, comprised of Drs. Eddie Lang, Stacy Kitts, Kirat Grawal, and Peter Oraklius. The Scientific Planning Committee members have no conflicts of interest to declare. This program received financial support from GSK in the form of an education grant. All efforts were made to mitigate any potential biases. We'll be using generic drug names whenever they come up. So COPD management is an important topic for emergency medicine physicians. There has not been a lot of new evidence produced on acute exacerbations of COPD recently. This has caused a drift from the original evidence-based guidelines to practices that employ significant personal variations, integrating practice location and available resources. Many guidelines are under the assumption that the emerge physician has a full host of tertiary ED tools at their disposal, which is not the case for many of our rural colleagues. Additionally, there are few options for follow-up in the community for some patients due to population growth and an undersupply of primary care clinicians. Without this outpatient follow-up, the traditional discharge plan is no longer a reassuring strategy. This places additional importance on the decisions by emergency medicine physicians regarding patient suitability for discharge and the use of evidence-based outpatient management. Our learning objectives are thus as follows. Number one, to identify patients with acute exacerbations of COPD who are suitable for outpatient management and initiate evidence-based treatments. Number two, to formulate an approach to investigate pulmonary embolism in patients presenting with AE-COPD. And number three, to manage critically ill patients with COPD exacerbations and effectively use non-invasive ventilation in both community and urban emergency medicine settings. To increase the interactivity of this session, we encourage you to use the chat feature to submit your questions, and we'll try to address as many of those as we can at the end of the lecture. I will be monitoring the chat area. We will be conducting some audience polling throughout the webinar, and for that, you'll need to have access to the Mentimeter website, which you can access via the website and typing in that code or using the QR code on the screen with your phone. You'll be prompted to enter that numeric code on the screen if you use the website access and answer each question as it comes up. And without further ado, I'd like to introduce our speakers. Dr. Brian Rowe is a professor in the Department of Emergency Medicine in the School of Public Health in the College of Health Sciences at the University of Alberta. He held a Tier 1 Canada Research Chair funding in evidence-based emergency medicine from 2001 to 2018. He recently completed 2 terms as a scientific director of the Institute of Circulatory and Respiratory Health at the Canadian Institute of Health Research from 2015 to 2023. He was also editor of the textbook Evidence-Based Emergency Medicine, has authored over 620 peer-reviewed manuscripts, and contributed to 38 book chapters. He was elected as a member to the Canadian Academy of Health Sciences in 2015. Dr. Rowe's disclosures are as follows. Dr. Bo Zheng is an emergency physician at the University of Alberta Hospital and a clinical lecturer within the University of Alberta Department of Emergency Medicine. He completed residency training in emergency medicine with a clinical epidemiology research fellowship at the University of Ottawa. He completed a Master's of Science in Epidemiology, and his thesis examined the role of antibiotics in the management of exacerbations of chronic obstructive pulmonary disease, or COPD. He is an early career clinician investigator with an interest in respiratory illnesses within emergency medicine. Dr. Zheng's disclosures are as follows on the slide. So let's get started with the first polling question. You can see which NHL team has the best chance of winning the Stanley Cup this season. Now, due to limitations within the software, we had to limit it to 6 options. So we had to pick one team to cut. Unfortunately, going by statistics, we removed the one least likely to win this year. So Toronto is not displayed on the screen. My apologies. If you're in Ontario, feel free to vote for Ottawa as well. I mean, they're a close second there. Okay. Looks like some strong showing for Edmonton there this year, which is great. I agree. So let's move on to our first case. Dr. Zheng, over to you.
All right. Thanks, Kevin. So good afternoon, everyone. And we'll start things off with a case. So we have a 68-year-old female who presents to the ED with a 7-day history of dyspnea, increased sputum volume, and increased sputum purulence. She denies any chest pain. She appears well. She's talking in full sentences. She's alert and oriented. Her vitals are as shown, fairly normal with elevated respiratory rate of 22 and an SpO2 of 94% on room air. On exam, there's no peripheral edema. There's no signs of increased work of breathing. She does have end expiratory wheezing diffusely, no crackles. And so she gets salbutamol and ipratropium, 4 puffs each. And afterwards, she's feeling much better, and she's wanting to go home because she has tickets to the Oilers game. So I'll hand it over to Dr. Rowe for a brief introduction about COPD.
Very much, Bo. Sorry, I have a bit of a croaky voice. I have a man cold, and so I'll just carry on. Hopefully you can hear me. So we all here believe COPD is an important health problem in the emergency department. We won't go into great detail about the epidemiology of the disease, but on the right-hand side, you can see the main causes of death in Canada. And cancer and cardiovascular disease are number 1 and number 2, but respiratory is number 3. And the most common cause of death in respiratory conditions is from COPD. If you look at the left-hand side, if you believe birth is a condition, then COPD and bronchitis are the second leading cause of hospitalization in Canada. If, like me, you think giving birth is not a condition, it's number 1 in presentations and hospitalization. These hospitalizations result in a fairly long length of stay, and so the burden on Canadian healthcare is quite large with respect to hospital stays from COPD. And then when you look at what the top 5 reasons why people say they go to see their primary care provider, respiratory conditions are number 2. So it's an important primary care problem. It's an important acute care problem, and it's an important cause of death in Canadian society. Next slide. And then when the exacerbations occur, because they're relatively severe, many of these patients end up in the emergency department. They present like this patient with increased dyspnea, increased sputum, and increased sputum purulence. They have often a prolonged deterioration over several days, as opposed to the other major wheezing condition that we see in emergency medicine, which is asthma that can come on very quickly. Because it's severe, in some cases, they require EMS transport and ED visits, and admissions are common to the hospital from the emergency department. Previous studies in this area include the MARC study, which was a 37 site study in Canada and the US, had a 60% admission rate. We did a CAPE study of 16 EDs in 2009, and that had an admission rate of about 50%. Ian Steele's work on the clinical decision rule had about 45%. So although admissions are declining somewhat, 50% would be a reasonable admission rate in a high volume tertiary care hospital. So it does vary, but admissions are common. Next slide. And I think one of the things that we wanted to talk about today was the difference between asthma and COPD. Many patients over the age of 45 who come into the hospital will tell clinicians and nurses that they have asthma. But, from the definition of asthma, they clearly don't have asthma, they have COPD. So COPD comes on later. It's more common in men than women, whereas in asthma, boys have more asthma than girls, and women have more asthma than men. There's usually not a family history of disease in COPD, whereas in asthma there is. Allergic conditions are common in asthma, but uncommon in COPD. Some people with asthma will still smoke, but it tends to be non-contributory. They develop the asthma prior to smoking, whereas COPD is almost always in North America related to cigarette consumption. We may see an influx of conditions associated with vaping, but overall this is a condition that's largely due to nicotine addiction through smoking. There's a lot of comorbidities in COPD, whereas most patients with asthma are younger, and they may have the occasional comorbidity, but not as severe as the folks that have COPD. The course of exacerbations in COPD are very different than asthma. Patients develop some permanent damage and never really return to their baseline, whereas in asthma, with good treatment, people can exceed their baseline in the recovery period. Most patients with COPD have a fixed airway obstruction with limited or blunted response to short-acting beta agonists, and their FEV1 to FVC ratio is less than 0.7. We do see some patients with asthma who have a FEV1 to FVC ratio of less than 0.7, but they're people that had bad treatment, and over time their FEV1 to FVC ratio will improve above 0.7. So I think that you have to be suspicious of any patient who's over 45 who says their doctor has told them they've got something like asthma. That's likely COPD, and we need to call the diagnosis COPD because the treatments are very different, as we'll see throughout the lecture. Next slide.
All right, so every time we see a patient in the emergency department, we're always asking ourselves, can this patient go home? And these, I think, would be the most important factors to consider for any patient coming in with a COPD exacerbation. In terms of vital signs and response to initial treatment, that's fairly obvious and self-explanatory, and I think pretty much all of us are looking at that already. In terms of comorbidities, that's also fairly self-explanatory, but in particular for COPD exacerbations, people with anemia, chronic kidney disease, CHF, coronary artery disease, all those comorbidities can put them at higher risk for adverse events. For social factors, it's important to always ask yourself, does this patient have stable housing? Does this patient live by themselves, or do they have home supports? Are they able to fill their prescription? Do you think they'll be able to be compliant with their treatment as prescribed? And so The first four items are fairly common to all conditions that we see in the emerge. And I want to spend a bit more time on the last two, which is the clinical decision rule and the 3-minute walk test, because these are a bit more specific to COPD. And so this is the Ottawa COPD risk scale. This was derived and validated in the past 5 to 10 years. And he used Canadian data, and it was a multi-center study that looked at emergency department patients with COPD exacerbations. And so you can see the elements of this clinical decision rule here. And basically that translates into a total score, which will give you a percent risk of serious adverse events. And you can easily look up this rule on MD Calc, so you don't have to remember any of this. So for serious adverse events, the way they defined that was they followed the patients for 14 days, and it was a composite outcome of all bad things, such as death, need for intubation, need for non-invasive ventilation, return to hospital with admission, and return to hospital with admission to a monitored unit like ICU. Overall, I think for a lot of patients that we see who are obviously unwell and need to be admitted, or obviously well and can go home, we don't necessarily need to or want to use this rule. But I think the most useful case for this rule may be for those patients kind of in the middle where we're a bit unsure about whether or not we should send them home. Alternatively, if there's a patient that we're trying to advocate for admission, and say they score relatively high on this tool, that's something that you can talk about with your consultants over the phone. Now, during the derivation of this rule, they looked at numerous different variables to see which ones would be associated with serious adverse events. And one of the variables that was highly associated with serious adverse events was being too ill to do a 3-minute walk test. And the 3-minute walk test was simply having the patient walk for 3 minutes continuously in the emergency department, unassisted. If they usually use a gait aid, they are able to use their usual gait aid. If they're usually on home oxygen, they're able to use home oxygen at their normal amount, but not more than that. And if they weren't able to do that, you can see that that was fairly predictive of the serious adverse event. Now, this variable actually didn't make it into the tool in the end, but to me, I think it makes intuitive sense to assess patients with COPD exacerbations by walking them in the emerge. And I think a lot of us are probably already doing this, and we'll probably ask the nurse or the RT to also put a SAT probe on the patient and check their SATs and heart rate while they're walking. But what was interesting about this data, if you look at the other variables, the baseline heart rate while walking, the SAT while walking, the highest heart rate or the lowest SAT while walking, and then the heart rate being over 110 or the SAT being below 88, all of these weren't actually associated with serious adverse events. And so for me, the takeaway here would be, if a patient is walking around and their SAT drops to maybe 87 or 86, or if their heart rate goes up to 110, that's not necessarily as important as whether the patient was able to complete the walk test at all. And so I think this is probably one of the best sources of evidence for using the walk test, which I know probably a lot of people do in their practice. And so once again, these are the factors to consider for any patient with a COPD exacerbation when you're thinking about sending them home. And we'll bring it back to our case here of our 68-year-old lady. And I think most of us will probably agree that she's likely well enough to go home. And when you go to send her home, she asks you, do I need any prescriptions? And then that's when you think about the pharmacologic treatment for acute exacerbations of COPD. So we all know about bronchodilators, specifically salbutamol and ipratropium. And we know that there's no difference between MDI versus nebulization when given in the emergency department. The recommended dose for the bronchodilators would be 2 to 4 puffs every 1 hour as needed. For some reason, I've noticed that emerge docs, when they order bronchodilators, they like the number of puffs to be a multiple of 4. So what I've noticed is some patients, they end up getting 8 or 12 puffs of Ventolin within an hour, and that's probably a little bit too much. The risks of beta agonist toxicity include things like hypokalemia or lactic acidosis, and probably most importantly, something like tachyarrhythmias, which may not be trivial for some patients. In terms of systemic corticosteroids, the recommended dose for prednisone would be 40 to 50 milligrams per day for 5 days. And then the IV equivalent for that would be 40 milligrams of methylprednisolone. Because prednisone comes in either a 5 milligram tab or a 50 milligram tab, it's usually a lot easier for patients to just take a 1 tab of 50 milligrams of prednisone per day. And then in terms of antibiotics, this is an area that still remains controversial, and we'll talk a bit more about this right now, actually. And so that brings us to our second polling question, which is, what do you use to help guide antibiotic use for COPD exacerbations? And you can select all that apply.
Really need a few more people to join Mentimeter.
All right, so I'm seeing a lot of people say clinical symptoms, a lot of people saying chest X-ray, and then a few people saying maybe everyone should get antibiotics, and then a few people saying CRP and the CBC. Uh, and so this is pretty much in line with what the evidence would say. So in terms of the evidence for antibiotic use in COPD exacerbations, most of us would be familiar with the Anton-Nielsen criteria. And so this criteria consists of 3 symptoms, the 3 cardinal symptoms of dyspnea, increased sputum volume, and increased sputum purulence. And currently, the guidelines will recommend antibiotics be prescribed if a patient is having 2 out of those 3 or 3 out of the 3. And this recommendation has been held true for probably the last 30 to 40 years. And it originated based on one single study that actually was done in Winnipeg, in Manitoba, by Nick Anthonyson, one of the respirologists. And this study was published back in 1987. And so if you think back to 1987, this was back when Wayne Gretzky was still playing for the Oilers in Edmonton before he moved to LA. And then this was also when Mike Tyson, at the age of 21, first became the undisputed heavyweight champion of the world. But anyway, Anthonyson did an RCT of patients coming in with COPD exacerbations, and he split the patient population into 3 groups. The first group he called Anthonyson type 1. Well, actually, he just called it type 1, which meant this patient only had 1 of the 3 symptoms. And then the second group he called type 2, which means they had 2 out of the 3. And then the third group, it was type 3, and they had 3 out of the 3. And then basically what the study showed was that antibiotics only benefited patients with type 2 or type 3 exacerbations. And so one of the possible critiques of this study is that for patients to report their sputum volume and sputum purulence, sometimes it can be quite subjective and may not be entirely reliable. And so a lot of other studies have looked at the topic of antibiotics for COPD exacerbations. And based on the latest systematic reviews and meta-analyses, it kind of looks like exacerbation severity plays a role. So there's a clear benefit for patients who have very severe exacerbations who need to be admitted to the ICU. So all of these patients should get antibiotics. And for patients who are otherwise admitted to an inpatient setting, the benefit is less pronounced, but there is likely still benefit for all comers, regardless of anthenecin type. And then for outpatient settings, again, it's less pronounced, and there may still be some benefit, but it's a very controversial area right now. And so more recently, some people have looked at CRP or C-reactive protein to see if they can use this as a tool to reduce the prescriptions of antibiotics in COPD. And so there was a study that was published in 2018 that was done in the UK at multiple primary care clinics that used a CRP cutoff of 20. And what they did was if someone with a COPD exacerbation had a CRP of less than 20, they would say no antibiotics. And then they compared that group to a group that got usual or standard care. And they noticed that the outcomes were basically the same, and including their quality of life was also the same. And so a CRP cutoff of 20 may be appropriate to withhold antibiotics. But this study was done, it was a good study, but it was done in primary care clinics. And so that patient population likely is not entirely the same as our patients that we see in the emergency department. And so we'll move on to our next polling question. So what antibiotic would you generally select for this patient from our case when you discharge her? Okay, so most people are saying either something like amoxiclav or doxy. A few people saying a macrolide. More people saying macrolide. So we're kind of all over the board, which is actually what I expected. All of these antibiotics are actually fairly reasonable. There are a few important points to note, however. So for macrolides, we know that there are high rates of strep pneumo resistance, and strep pneumo is quite a common, it's actually the most common respiratory bug for pneumonia. And so whether you're treating COPD exacerbations or pneumonia, macrolide monotherapy, probably not the best thing to do. Beta-lactams are very good at covering all your typical respiratory organisms. So something like amoxiclav would probably be my first-line antibiotic here. Beta-lactam plus macrolide, this would be kind of our standard pneumonia treatment, covering both typical and atypical organisms. But the important thing to note here is your antibiotic choice for COPD exacerbations doesn't necessarily have to be the same as your antibiotic choice for pneumonia treatment, because you don't necessarily need to cover for respiratory atypical organisms. So using a beta-lactam alone is probably adequate, unless the patient has a pneumonia on their X-ray. Fluoroquinolones are very broad in their coverage. They're once a day dosing, so that makes it good. But the side effect profile is probably not as good as beta-lactams, and they're also known for a lot of drug-drug interactions. So probably would be my second or third line. And then a tetracycline like doxycycline would also be a good choice, especially if someone might have an allergy to a beta-lactam. All right, so the take-home points from our first case, it's important to differentiate between asthma and COPD. Consider things like vitals, response to treatment, comorbidities, social factors, and walk tests when deciding who to discharge. Bronchodilators and corticosteroids are indicated for all COPD exacerbations, and then considering antibiotics if your patient has increased sputum volume and increased sputum purulence, or if they're having a very severe exacerbation and needing to be admitted, and especially if they need to be admitted to the ICU. All right, so I'll hand it over to Dr. Rowe again for our second case.
Okay, I thought Kevin was doing this, but that's cool. So the second case is a 73-year-old male who presents to the ED with a 3-day history of dyspnea, increased sputum volume and purulence, and some pleuritic chest pain. Appears dyspneic with a respiratory rate of 28, but not particularly unwell. No tripod posturing. Saturations are slightly low on room air. Has a mild temperature, 37.8, heart rate 114, and normal blood pressure. Next slide. On examination, there's no peripheral edema, no unilateral leg swelling, decreased air entry to the bases, an inspiratory-expiratory rate of a ratio of 1:3, meaning they have prolonged expiratory phase with diffuse wheezing. No crackles are heard. Management is started in the emergency department with 50 milligrams of oral prednisone. And as Bo mentioned, steroids are indicated, and really only the sickest patients should be given intravenous systemic corticosteroids. Most people can absorb prednisone orally, and that will ensure that most patients are getting this from the start. Also given oxygen by nasal prongs and started on 4 puffs of salbutamol and 4 puffs of ipratropium bromide ×3 going forward. Next slide. So apart from routine labs and a chest x-ray, would you order a D-dimer? There's only 3 options here. So maybe if somebody wants to write in the Toronto Maple Leafs here, you could. So yes, immediately. No, the diagnosis is AE-COPD, or a delayed approach based on the chest x-ray and response to treatment. Doesn't look like we've got a lot of no's. No, the diagnosis is AE-COPD. So we got about 2/3 are saying delayed, and a third are saying immediately. Okay, maybe just we can move to the next one. So that's those 2 options. So the causes of AE-COPD, most commonly viral. Sometimes we see, particularly in the summer times with all the wildfires and poor air quality, we get exacerbations. I can imagine India right now must be experiencing a lot of air issues with respiratory conditions due to their poor air quality. Sometimes it's a natural progression of the disease or poor adherence to chronic medication. It's less likely to be pneumonia. Sometimes there's pneumothorax or pneumomediastinum that occurs. And the bigger question for most of the emergency physicians in the audience would be, do we test this person for pulmonary embolism? They have a bit of pleuritic chest pain. They do have symptoms consistent with an AE-COPD exacerbation with antenescent criteria suggesting antibiotics and prednisone. So the question that we were posed prior to developing these slides was, what do you do with respect to patients with AE-COPD and investigations for pulmonary embolism? So next slide. So again, most of you would do a chest X-ray, some electrolytes, CBC and ECG. That'll rule out a pneumonia, anemia, electrolyte imbalance, and any obvious ischemia. If the chest pain is more concerning for myocardial ischemia, people add a high sensitivity troponin. And then if there's a question about acute heart failure in combination with AE-COPD, some people add a BNP. My colleagues in the United States have a triple treatment. They do D-dimer, high sensitivity troponin, and BNP on pretty much anybody who's got a lung. It's a little different in Canada. I think our approach is, while conservative, evidence-based. And we understand that ED physicians are concerned about missing a pulmonary embolism, but there's a lot of evidence to suggest we're over testing for this. In our own center, about 17% of people with AE-COPD get some type of investigation for pulmonary embolism. Of those patients, 84% are getting a D-dimer, 44% are getting a chest CT, and about 3% are getting a VQ scan. So you can see that for a pretty common problem, there's a lot of investigations for that. The estimates for pulmonary embolism vary considerably. So there's been several systematic reviews on this, and about 11 to 12% of all patients with AE-COPD in these studies had a underlying PE. That seems like a lot to me. And when you really look at these systematic reviews in detail, you'll find that most of the studies involve patients that require hospitalization. So obviously, the patients that are really sick, you might need to think about PE in those cases. But among the patients or the included studies, only one study included patients from the ED and found a lower prevalence of PE, about 3 to 4%. And there have been a couple of other studies showing similar rates. So we're looking not at 10%, we're looking at 2 to 3% of patients with AE-COPD having a PE. And the investigation varies widely, again, suggesting a lack of evidence. For example, oftentimes people get a CT-PE without a D-dimer. And then sometimes a D-dimer is ordered, it's positive, and no advanced imaging is done to confirm or rule out the diagnosis of PE. And again, our own experience locally would be that 17% of people get investigated for a PE, and that the incidence of PE is around 1 to 2%. So again, I think if we look at this carefully, these patients largely don't have PE, and we're overestimating the risk, and we're exposing people to a lot of radiation in the emergency department. Next slide. So our approach is based on the current evidence available. Because we're Canadian, and because I know Phil Wells very well, I contacted him to make sure we weren't, misdirecting you, let's say. So the first thing is to do a complete history and physical examination, looking for evidence of venous thromboembolism, including evidence of DVT. And you might think more about a PE when the presentation is associated with atypical COPD symptoms like syncope, more common with chest pain, and non-traditional kind of findings. We would generally treat these patients with antibiotics and corticosteroids, as we've described, and think about PE when perhaps they're not responding. Next, we'd say, well, use a clinical decision rule. Obviously, the PERC rule is not applicable in this case because most of these patients are over 50. But we would use a clinical decision rule to decide on the pretest probability of PE in this group. Because Phil is a Canadian and a world-renowned researcher, we would likely use the Wells criteria, but there are other ones available. And these are, again, as Bo said, available easily on MedCalc. And then in patients with increased risk or a non-low risk pretest probability, obtaining a D-dimer and considering age adjustment because of the age of these patients, would be the next recommendation. And then doing a CTPE on cases where D-dimer is positive and response to therapy fails. You might argue that patients who are admitted because their rate is 11 to 12%, that might be a situation where you consider investigating for PE. But overall, I think this approach, which has been confirmed by the guru himself, makes a lot of sense. Next slide. So take-home points from case number 2. It's important to consider causes and or complications of AE COPD. To rule out PE, a history and physical, a clinical decision rule, and an age-adjusted D-dimer would be reasonable, and obtaining a CTPE in selected cases would be a reasonable approach, and perhaps would be one of the areas where we could really improve the treatment in AE COPD. Next slide. I think it goes back to you, Bill.
Yep. Thanks, Brian. So we'll move on to the third and final case of our talk. So you now have a 78-year-old male who presents to the ED with a one-day history of dyspnea, increased sputum, and chest pain. He appears unwell with pursed lip breathing, accessory muscle use, and tripod posturing. His vitals are as shown. His respiratory rate is 32, heart rate 110, and his SpO2 on room air is 76. On exam, there's no peripheral edema. He has a quiet chest with a prolonged expiratory phase, and he has wheezing diffusely, no crackles. And so you get some investigation started, and you start him on our standard COPD exacerbation management. And at this point, you might also be thinking, this guy sounds pretty unwell, and you might be considering something like BiPAP. And you would be absolutely correct. And so BiPAP, or non-invasive ventilation, is about as close to a miracle as we have for the acute management of severe COPD exacerbations. The main indications would be for a respiratory acidosis, usually caused by hypercapnia, persistent hypoxemia, and severe dyspnea or increased work of breathing. There is also a list of contraindications for non-invasive ventilation. One of them would be altered mental status, but I think this would be more of a relative contraindication because a lot of the times when patients with COPD exacerbations are hypercapnic, they may be a bit drowsy or even confused, but non-invasive ventilation usually is able to fix that. Other contraindications would be hemodynamic instability or active vomiting. In terms of the evidence for non-invasive ventilation, we know that it decreases intubations, and we also know that there's a mortality benefit as well. Now, if you work at a place with a respiratory therapist, they'll usually be able to set everything up for you. If you work in a place with no respiratory therapist and you're the one who needs to know how to set up the BiPAP machine, this slide is a good starting point in terms of the initial settings, but I would highly recommend to actually try to go through the motions and set up the machine yourself. And if you're unsure about how to do it, have someone who knows what they're doing. So BiPAP machines will vary depending on the brand and the model, but they'll generally have these initial settings that you'll need to set. So the two main numbers would be the IPAP and the EPAP. So IPAP stands for inspiratory positive airway pressure, and then EPAP stands for expiratory positive airway pressure. And the EPAP is the same concept as CPAP or PEEP, which is basically just like a continuous positive airway pressure. And then the IPAP is the pressure on top of the EPAP. For the IPAP, it's reasonable to start at 10. For the EPAP, you can just start at 5. For many patients, you will need to titrate the IPAP higher, depending on their body habitus and depending on what kinds of volumes you get. Usually, tidal volumes of 500 cc's and over would be considered acceptable. or like 8 feces per kilo of ideal body weight. But generally, we wouldn't want an IPAP over 20. In terms of the FiO2, if the patient is really unwell, you can just dial it up to 100% and then slowly titrate down afterwards. For the rate, you can just start at 10 breaths per minute. And keep in mind, this is just a backup rate. This is only active if the patient becomes apneic or stops breathing for whatever reason while on the BiPAP machine. This should go without saying, but if your patient has no spontaneous respiratory efforts, that would be an absolute contraindication for non-invasive ventilation. You might also see something called the rise time or the I time. It's basically the time that the machine takes to increase the pressure from the EPAP level to the IPAP level. And for that, you can just select the fastest or the shortest time. And that's to decrease the time spent in inspiration and to maximize the time spent in expiration. So we'll go back to our case now. And after about 10 minutes of BiPAP, your patient becomes agitated and confused, and he's persistently trying to rip the mask off. It's difficult to get a good waveform for the SpO2, but the monitor is showing somewhere between 80 to 85. And the initial VBG comes back and it shows a pH of 7.12, PCO2 of 89, and a bicarb of 28. So in this situation, how do you proceed?
Maybe some people are calling a priest right now. So we didn't mean as an instruction.
There's just about a 15-second delay from when you guys talk to the slide showing up for them.
Yeah, it's actually interesting to see the spread of the different options because I had no idea what to expect when I made this question. But definitely a tough situation, and we're kind of venturing into an area where there's no evidence to really guide our practice. And I think in the right circumstance, you could probably make an argument for probably all of these options. So the first one, which is to continue BiPAP and have your staff trying to coach him through it and hold him down and maybe soft restraints if necessary. That's probably the easiest and first option that most people will try. And you can try it for a short period of time. And sometimes, patients will only be agitated for a short period of time. But usually the success rate with that option alone is going to be pretty low. The second option, which is to give sedation while on BiPAP, that's actually a very interesting option, which we'll talk a little bit more about after this slide. And I think would be a very reasonable option here. If you are going to give a sedation agent, I would definitely avoid anything that depresses your respiratory drive, so opioids or benzodiazepines. A good agent to consider would be something like ketamine, which doesn't or shouldn't affect your respiratory drive. And it's hemodynamically stable and also has a mild bronchodilatory effect. An alternative to ketamine may be an antipsychotic, so something like an haloperidol in low doses is also unlikely to affect your respiratory drive. And this can sometimes bridge the patient to having a lower PCO2 and maybe their confusion and agitation will improve. But it can also bridge the patient to a safer intubation. Now, the next option, the immediate intubation, that option is probably the most textbook answer for this question. What we basically described in the previous slide is failure of non-invasive ventilation. And if this was like a test or oral exam scenario, I think that this option would be definitely the correct one, so to speak. But in real life, we know there's a number of reasons why we wouldn't always just jump to immediate intubation for a patient like this. Calling ICU is not a bad idea when you have a critically ill patient, and it's never a bad idea to call a friend. And it doesn't have to be ICU. It can be, a respirologist, an internist, or another emerge doc. And then the last option, so calling the priest. So obviously this is worded facetiously, but there is an underlying point to this, and the point is goals of care conversations are very important for any critically ill patient with a COPD exacerbation. And so sometimes patients will have pre-expressed wishes or goals of care documented, but a lot of times you may have to sit down with the substitute decision maker and have a frank conversation about the prognosis and whether or not the patient would be a candidate for intubation and life-sustaining therapies. So I want to talk about this because it's probably something a lot of people have heard about, but I don't think happens that much in real life. And it is relevant to the scenario that we just described. And so basically, this is a paper that came out in 2015, and in it, Scott Weingart describes a small cohort of patients who required emergency intubation, but they were also agitated, which made pre-oxygenation very difficult. And so what they did was they started non-invasive ventilation and also gave a dose of ketamine at a dose of 1 milligram per kilogram. And they found that that worked quite well to facilitate the pre-oxygenation and a smoother intubation. And so I think for our patients, this would support the decision to sedate the patient while on BiPAP with something like ketamine, whether or not you end up ultimately deciding to intubate them in the end. This is another paper kind of along the same lines that actually just came out earlier this year. And this was a multi-center RCT, and they compared non-invasive ventilation versus our usual non-rebreather and BVM for pre-oxygenation during emergency intubation. And this was intubation of all comers, so not just COPD, but intubation for sepsis or neurologic emergencies, everyone. And what they found was the group that had non-invasive ventilation for pre-oxygenation actually had much lower rates of hypoxemia during the intubation itself. And so, again, I think this speaks to the utility of non-invasive ventilation. Even if with the plan of intubation, it can be something that you use for pre-oxygenation and facilitate a safer intubation. The last thing I'll touch on is IV magnesium for COPD exacerbations. Now, many of us are probably familiar with using magnesium for asthma exacerbations, but there is a little bit of evidence to suggest that magnesium is beneficial in COPD as well. So in this Cochrane review, they actually found that magnesium, when compared to placebo, decreased the need for admission for patients with COPD exacerbations. They only had 3 studies, and all of these studies were small in sample size, but they were all RCTs though. But nevertheless, I think the risks of magnesium are low enough that it would definitely be something worth considering, regardless of the severity of COPD. And the dose would be basically the same as asthma, which is 2 grams IV over 20 minutes. And so these are the take-home points from our last case. So non-invasive ventilation saves lives. Magnesium sulfate may be helpful, and avoid intubation if possible. So I'll hand it back to Dr. Rowe for some final thoughts.
Yeah, thanks very much, Bo. And I think that last case is really important because magnesium is freely available. We use it in asthma, it's incredibly safe. And if it could help you avoid intubation, that would be, you've done everything you possibly can in those patients to prevent them from being intubated, which is perhaps the worst thing we can do to people with AE COPD. So we're going to quickly wrap up because we've got a couple of really good questions, and we may have to go a couple of minutes over, but there's a couple of other additional considerations. Follow-up for these patients is critically important. Many of these patients don't get seen by primary care up to 3 weeks after their ED visit. These are sentinel events in their lives. Issues need to be reassessed. It's hard to find family doctors and primary care providers in Canada, but reassessment is strongly encouraged for these patients. We haven't mentioned anything about triple therapy with ICS LABA/LAMA because there are no specific trials out of the emergency department that look at this. So we're going to add, for most patients, we're going to add systemic corticosteroids and antibiotics. That's a lot for people to leave the emergency department with. We would strongly recommend are encouraged to be compliant or adherent with their chronic medications and to take these prescriptions for the duration of the prescription. Obviously, this is a sentinel teachable moment for most patients with COPD. We should always ask about smoking and vaping, although vaping is uncommon in the elderly. Smoking is still a big problem, and one of the best things we can do is encourage them to look at stopping smoking and referring them on to cessation options that are usually regional or local in their origin. Vaccinations are important. Despite the recent appointment of JFK Jr. to health portfolio in the United States, in Canada, we still believe influenza, pneumococcal, and COVID-19 vaccinations. Now there's RSV, and that's a newer area where we need to explore. I would encourage people to get vaccinated, not obviously in the emergency department. And then finally, rehabilitation. The pulmonologist would say, you can do all you want in the emergency department, but the most effective strategy for these patients is rehabilitation. It's often not available outside of the teaching centers, but there are now online rehabilitation programs, community-based rehabilitation programs, and they look at things like exercise training, nutrition, breathing techniques, education, and really can be started within a month of an exacerbation. So if you have options for that in your community, again, patients should be referred to that. They have far less readmissions to the hospital and a better quality of life after rehabilitation. So that's the end of the presentation. I think Kevin's been monitoring the questions, and Bo is ready and able to answer all of them.
Thanks, Dr. Rowe and Dr. Zheng, for this informative talk. I'd like to thank everyone who joined in today, the Scientific Planning Committee for their invaluable input, the CAPE staff team for their hard work behind the scenes, and our IT support. This session's been accredited by the College of Family Physicians of Canada and the Royal College of Physicians and Surgeons. Don't forget to complete your evaluation form and claim your CPD credits. A certificate of attendance will be mailed out by CAPE together with the evaluation link. I'm just going to go through the questions because there's been some really good ones that I think would be great to answer here if you have a few minutes to stick around. So the first one was Hamad asks, was too ill to do the walk test defined as unable to complete a 3-minute walk test irrespective of changes to vitals?
Yeah, so basically they couldn't walk for the full 3 minutes, or like it didn't matter what the vitals were, or they, were too weak to get up, or for whatever reason they couldn't complete walking for 3 minutes.
Okay. Jesse asks, is it possible to have an acute exacerbation of COPD without dyspnea? Because it's one of those 3 criteria and you're looking for 2 of 3. So can you have a COPD without dyspnea?
I think it would be fairly uncommon. Although if you look at kind of the symptoms that could represent an exacerbation, something like just like an isolated cough could also represent perhaps like a subtle COPD exacerbation. But I think for the most part, you're going to have at least one of those symptoms of dyspnea, sputum volume, or sputum purulence.
Yeah, and I would just add that you really have to ask the questions properly when you're talking about sputum. I know people don't like to talk about sputum. My kids find it funny that I talk about sputum, but you ask them, has the consistency of your sputum changed? Is there any change in color? That's the kind of question you need to ask, because they'll say, no, things haven't changed. Then you'll ask them in more detail, and they'll say, yeah, there's definitely a different stickiness or thickness to it. So again, I think there's very few people, particularly in severe AE-COPD, that don't have dyspnea, increased sputum, or purulence. So it's really important to ask those questions.
Yeah, I get his point, just that it seems like having one of the three criteria be dyspnea when everybody with an AE-COPD is dyspneic, then why not just have the other two criteria as your criteria for COPD exacerbation? But I guess that could be debated with the Winnipeg crew. A similar question between John and Julie. Is there any maintenance inhaler for the COPD patient if they're not on one, or any guidance for puffers at home considering cost for the patient?
Yeah, I can step in. The recommendations are for the triple therapy, and again, I think if the patient's not on anything, then they probably should be started on something. But that likely is something that needs to be done by the primary care provider.
Okay. Jesse asks, what about years as a rule out for this patient population?
Yeah, there has a lot of the studies on on pulmonary embolism have been done, including patients with COPD. So again, the guideline is best evidence. I think if you're using that as a common clinical decision aid, I think that's reasonable.
Okay. Susan asked, is there any role for Airvo or high flow nasal cannula for those who don't have Airvo?
Yeah, that's a great question, actually. And so there's no evidence to suggest that high flow nasal cannula will have the same benefits as like BiPAP or CPAP. And I think it really comes down to the amount of positive pressure. I know there's probably some esoteric, like OR studies of high flow nasal cannula saying that it does provide some positive pressure. But really, like practically speaking, it's kind of a different level compared to BiPAP or CPAP. And so I wouldn't expect that you would get the same benefits. If the patient is really not tolerating BiPAP, for example, and you have no other option, if say they're not a candidate for intubation, you could potentially try high flow nasal cannula. It probably won't do any harm. But just know that the benefits or the evidence for benefit is not there.
Okay. Stan had a really good question too. So what if the Emerge doesn't have access to BiPAP? I know sometimes you can ask the EMS trucks if they have a CPAP machine, but do you guys have any other suggestions for these sites?
Yeah, that would be a very tough situation. I would say try to get the patient out as soon as possible. You could, yeah, like ask EMS crews. A lot of them carry BiPAP or sorry, CPAP with them these days. And the only other potential workaround would be to use the bag valve mask, and if you attach a PEEP valve to that, you can potentially give the patient anywhere from 5 to 10 to 15 of PEEP.
Okay, thanks. And last question here. What's the ketamine dose that you would use for this patient population, as you mentioned there?
Yeah, so I don't think there's a strict dosing guideline. In Scott Weingart's study, he used 1 milligram per kilogram, which seemed to work well for him based on the results of the study. In my experience, for older patients who are critically ill, you can use a much lower dose than the 1 milligram per kilogram and still achieve the same effects of basically dissociation. And so even if you started at 0.5 milligrams per kilogram, that might be reasonable. The the risk of doing that is for ketamine for any dose kind of between 0.1 to 1 milligram per kilogram, that kind of could put you at risk for kind of the recreational dose of ketamine, where patients kind of they don't get dissociated, but they feel all the effects of the drug, and for some people that could be quite distressing. So you do have to watch out for that risk if you choose to go with a lower dose. Using 1 milligram per kilogram is probably totally fine as well. You typically wouldn't expect any changes to your hemodynamics or your respiratory drive with that dose. But again, when patients are elderly and they're critically ill, I have also seen ketamine kind of change a patient's hemodynamics as well.
Great, and that's all the questions. I think we'll end it there. Thanks, everyone.